Good? You can't see my notes? Okay, perfect. So today we're talking about understanding Parkinson's disease dementia. There's going to be a lot of statistics in this because not everyone who develops Parkinson's is going to develop PDD, Parkinson's disease dementia, but that number has sure gone up over the years. So it's actually really interesting. I was telling Jamie as I was putting this program together, from when I started working in this field years ago, this particular disease, the Parkinson, we know so much more now. And so some of these, I've got the most up-to-date numbers, what we're going to look at today. And we're going to start with what is Parkinson's. You've got to start with that. What is Parkinson's disease? Because it is very different from other types of diseases. And Parkinson's disease is specific in that it's damaging the central nervous system. That's why most people, it presents with a tremor of the hands, or it presents with a change in their gait, the way they're walking. They'll get what's called a shuffle, where they're maybe starting to look at their feet or putting their arms out to their side, hunch over, because it's damaging the central nervous system. So it's known as a movement disorder. It actually has 5 stages, and we'll look at those 5 stages next. And those 5 stages, unlike dementias, where we just pretty much call it early, moderate, severe, but we can't really check off. With Parkinson's, they do tend to move through the 5 stages. 50% of people who have Parkinson's will experience hallucinations or delusions and delusions. And people will ask, what's the difference in a hallucination or a delusion? So a hallucination is whenever you've got a perception of something that's not there, like you're seeing someone sitting in a chair, or there's ants on the floor and there's nothing there. It's not that they're mistaken one thing for another, it's not there. But then a delusion is an impression that is not realistic or rational. This has to do with paranoid. I know you're here to take all of my money. You're coming to kill me. There's poison in my food, that type of thing. Also, 50% of people who develop Parkinson's will also develop what's called mild cognitive impairment, MCI. So the definition of mild cognitive impairment is when there are changes in memory and there's changes in thinking, and they're noticeable, but it's not enough to affect daily activities. So that's going to be a big difference in mild cognitive impairment and actual dementia. In dementia, we're going to see changes in memory and thinking that are noticeable, but they affect daily activities. There's the difference. Parkinson's mainly affects people over the age of 65. That doesn't mean everybody's over 65, though. I've known plenty of people that had early onset. This number is brand new. This is from the Alzheimer's Association. It is a 2020 number. Approximately 1 million people in the United States are now diagnosed with Parkinson's disease. That's huge. We talked about tremors. So Parkinson's disease itself, if you look on the list of fatal diseases, Parkinson's disease is not considered fatal. However, the complications of Parkinson's disease are fatal. Average life expectancy is 9 years, but there are those that live 20 and there are those that live 2. So that's why the average is 9. So here I've mentioned those 5 stages of Parkinson's disease, and they go, and Jamie found these great pictures here. And again, you're going to get copies of these, so you'll be able to see them a little bit better about what's actually happening in the brain of somebody with Parkinson's. So stage 1 is where they have the mild symptoms and it's just an inconvenience. Stage 2 is called bilateral, and it's where it's affecting both sides of the body, arms and legs. Stage 3 is where they're having more severe symptoms. Stage 4 is a progression of those severe symptoms. And stage 5 is complete immobility. So what you see happening there, Parkinson's affects the dopamine in the brain. And so we've got some great pictures here of what a healthy patient would look like and then what a Parkinson's patient would look like. And we're going to deep dive a little further into that. So then, what is Parkinson's disease dementia? Just like I said earlier, we're going to have a decline in thinking, reasoning, and problem solving enough to impact their daily living. Now, this is the number that has gone up tremendously in the last 10 to 12 years. When I first started working in this field, it was 40%. We would say 40% of those with Parkinson's will then develop Parkinson's dementia. And now it's 50 to 80%. Now, it may have been that back then and we just didn't know it. We didn't realize it. The research wasn't being done. 50 to 80% of those with Parkinson's will develop Parkinson's dementia. And then look at this statistic. Again, this is all from Alzheimer's, alz.org. If somebody lives 20 years, 20 plus years with Parkinson's, the chance of them developing Parkinson's dementia is 83%. Average time from onset of movement problems in Parkinson's to developing dementia is approximately 10 years. Now, Parkinson's dementia is fatal because all dementias are terminal. And then the average life expectancy with PDD is 7 years. Now, I know this is a huge list, but I wanted to make sure that you got the full impact of the symptoms of Parkinson's dementia. And the reason I wanted to put all of these on here, and this isn't all of them, this is all I could get on this slide that wasn't completely overwhelming, was because so many times when we hear that word dementia, we will hear memory loss. They forget, they can't remember. I did a huge big program the other day, almost 200 people on it, and I asked that group of mostly professionals even, tell me everything you know about dementia. And the majority of them said memory loss. There's a whole lot more to dementia than memory loss. So just because all of these are on here, that doesn't mean that they're going to have all of these symptoms. But so many times when we start to educate people about dementia, they'll look on there and go, I had no idea that that was part of dementia. So as you notice, some of them that are on there, the inability to apply reasoning and judgment, rational behavior, that's dementia. Now, some things that are specific to Parkinson's dementia, issues with speech like slurred speech, that type of thing, breathing and respiratory difficulties. These are part of that PDD. The swallowing problems a little earlier than we might see in somebody with other types of dementia. But issues with sequencing, we kind of see that across the board with all different types of dementia. Loss of interest, agitation, depression, anxiety, changes in energy levels, those type things. Now, with their delusions, somebody who has Parkinson's dementia, their delusions tend to be more on the paranoid side as well. So how do we get it diagnosed? Parkinson's disease dementia. So there's not a single test that can tell if somebody has PDD. It is a series of tests and indicators. So typically you're going to have a neurologist who diagnoses the Parkinson's, and then they are going to, at every checkup, going to be continuously monitoring and looking for, because the percentage is so high that they will develop Parkinson's dementia, they're going to be looking for this. Now, one of the things that they count on is that that care partner is keeping good notes. It's important with all of the dementias, but with Parkinson's dementia, with Parkinson's disease, as they're watching for signs of it turning to Parkinson's disease dementia, that care partner's there, they're the ones that's with them all the time. And so we've got to be taking good notes of their hallucinations, their delusions, changes that we're seeing in behavior. What were they doing at the time and what were they doing right before it happened? And then be able to go into the doctor and present them with this. We know we have a limited amount of time once we get in with that doctor, and we want to use every minute of it at the best that we can. We can even send those notes ahead of time so they can review them, because they're going to be looking for cognitive function changes. They're going to test them for memory recall. They're going to check their overall health. They're going to take a full medical and family history. And again, they're going to be doing so Parkinson's disease, I put down here on the bottom because I knew people would ask, so how do you even get diagnosed with Parkinson's? So you're at the neurologist, they're doing the family history, they're going to do some balance tests. Those of you who's had loved ones go through these tests, they actually will walk with them down the hall and they'll push them. They're looking for their startle, they're looking for how they correct. There's lots of observation of their movement disorders. They're going to do some imaging tests. They will likely do an MRI. They may do a PET scan. There's going to be a lot of lab work. They may do some muscle tests. And then many times they'll go ahead and do a lumbar puncture because they're looking for biomarkers of Parkinson's. So what then causes the Parkinson's disease dementia? And I thought this was a really good picture showing the difference in the brain of somebody who does not have dementia, one who has dementia with the low plaque deposits and one with the high plaque deposits. Because Parkinson's disease, Parkinson's itself, destroys that nerve cell that makes dopamine. And dopamine is a messenger that controls our coordination and our muscle movement. They do not know why it happens. This is one of those, that's why money is getting pushed into research in Parkinson's. Unlike Alzheimer's and other related dementias where we're not getting near as much money pushed in, we've had someone come forward and put a face to Parkinson's. And y'all know who that is. It's Michael J. Fox. Michael J. Fox came forward. He has testified before Congress. He testified before Congress off of his medication so they could see how severe his symptoms were. Bam, money gets pushed toward it. Plus, he created the Michael J. Fox Foundation and has raised so much money. I think that's why we've seen these numbers. The research is out there now with Parkinson's. But they still don't know why it happens. And if we don't know why it happens, we can't stop it. So as it progresses and it spreads in the brain, it can affect, this is if it's turning into that PDD, the Parkinson's disease dementia, the parts of the brain that are responsible for mental functions, memory, and judgment. So what are the risk factors of it turning from Parkinson's disease to Parkinson's disease dementia? Being a male is one of the risk factors. Not much we can do about that one. Being over the age of 60, there's another one, we can't do much about that one. If, while they have Parkinson's disease, they get diagnosed with that MCI, mild cognitive impairment, then their chances go up. If they have more severe symptoms of that motor impairment, such as getting rigid, having the freezing, literally freezing to the point that they will fall over. I have watched people fall right out of chairs. I have watched people just face plant on the floor because they just become rigid, then their chances are higher of developing dementia. Depression, and we just did a program Tuesday on depression and dementia. We're finding a lot of links now between untreated depression over a long period of time and the damage that it actually does to the chemicals in the brain. So if they already have depression, and then if they're having those paranoid hallucinations and delusions, their chances are higher of developing Parkinson's dementia. So what do we do to treat it? Because you just heard me say that there's not a treatment. So there's no specific treatment for any of the dementias, not just this one, for any of them. What we do is we treat the symptoms. There's some challenges with treating symptoms with Parkinson's though, just because of what's going on in the brain and because of what's going on with that lack of dopamine. So these are some of the things that they might try. And again, these are not all going to work for everyone. Usually it's trial and error. But many times they will start them on, you may have heard of Aricept or Exelon. Some people will even call those memory meds. They're really not memory meds. They're treating confusion. They're treating, they can treat visual hallucinations, sleep disturbances, problems, changes in their thinking. Sometimes. Some people have a lot of side effects from these, but they may try these. And Aricept and Exelon you see used across the board with most types of dementia. And then there is carbidopa-levodopa, which is used to treat Parkinson's movement disorders. However, it may help with the movement disorders, but it might make the hallucinations worse. So there's that trade-off, or we just can't use it. They may be able to treat the depression. That they may be able to do with some antidepressants. They may be able to use some medications to help treat some sleep disorders. So that's something that they can do. Typically in somebody with Parkinson's disease or Parkinson's disease dementia, they will not use that class of meds called an antipsychotic because of the chemicals in the brain, where you can use those medications with other types of dementias. But some of the best thing that we can do for those that have Parkinson's dementia is going in and out of physical therapy, occupational therapy, and speech therapy. These therapists are taught to tap into what's called muscle memory. They're going back and they're tapping into those muscles where we first learned to walk, we first learned to dress ourselves, to do our own grooming, to brush our teeth, to feed ourselves. Because think about when we learned that. We learned that at 18 months, 2 years, 3 years old. And they know how. People who are trained to do this can go back and tap into that muscle memory and then teach families even how to do that. So doctors will write orders for them to go in and out of PT, OT, ST throughout the course of the disease. Speech therapy also helps with swallowing issues. Many people don't realize because it's called speech therapy, but they can help with swallowing issues as well. So we have to talk about Lewy body dementia a little bit whenever we're talking about Parkinson's disease, because so many times a person will get a diagnosis of Parkinson's with Lewy body or Lewy body with Parkinson's. And there's a reason for that. The Lewy bodies, and I was telling Jamie, I just found this out yesterday. She already knew it, of course. But there was a doctor whose last name was Lewy, Dr. Lewy, who actually worked in the same lab with Dr. Alzheimer back in the early 1900s. And he is the one who found that there was a difference in the brains of these people who were having a little bit different behaviors, challenges. And so they named it a Lewy body. It's a foreign that's on the brain. And so it's called a Lewy body. So we see Lewy bodies on the brain of people who have Parkinson's disease. But not everybody who has Parkinson's develops Lewy body dementia. Why do some do it and some don't? We don't know. But Lewy body dementia is a progressive dementia caused by these abnormal deposits of a protein with a very long name. That's why I didn't put it on there. And it's also seen in Parkinson's disease. And those proteins are actually, it pulls the protein out of the nucleus of the brain cell, and then the brain cell dies. So it works very differently from other types of dementias. Now, the end result is the same, but they can see it now. But there's an overlap in symptoms. So many times, somebody who actually has Lewy body dementia will get misdiagnosed as Parkinson's first, or a person who has Parkinson's will get misdiagnosed as Lewy body first, and they may not have both, or they may, because you can have a dual diagnosis or a mixed diagnosis, and you can have both. The way they word it, they'll put the one they were diagnosed with first, Lewy body with Parkinson's, Parkinson's with Lewy body. Because they both have movement disorders, rigid muscles, problems with thinking and reasoning, hallucinations and delusions. So they overlap. This is what, if any of you recall, when Robin Williams died and his wife had an autopsy done, she had said he had been diagnosed with Parkinson's, and at autopsy, they found out he had Lewy body dementia. So what are some things that care partners can do for those that have Parkinson's disease dementia? When somebody is having a hallucination or a delusion, of course, we want to try to keep everything around them as calm as possible, but you cannot go up to somebody who's in the middle of a hallucination or a delusion and try to be rational or reason with them. And I am betting if you've ever done that, you know exactly what I'm talking about. You cannot bring them to our world. We have to go to their world. And this is where we get very, very good at therapeutic stories, because we may just have to go to their world. Let me give you an example. I had a woman who had Parkinson's disease dementia, who just knew that there were babies under all the furniture, because she was hearing them and she was seeing them. So she was having an auditory and a visual. I could not go in there and explain to her that there were no babies, because there were babies. She was seeing and hearing them. So I had to get down on the floor and start taking the babies out from under the bed and handing them up to the nurse to make sure they were okay. And I pulled babies out from under that bed until she told me I had them all. I went to her world. She calmed down because we started taking care of the babies. And then I immediately, once she told me I had all the babies out, I got her out of that room and went to our distraction techniques with food, music, animals, and children. In this case, I wouldn't have used children because she was having the hallucinations and delusions about children, but I sure used food, because I had someone, while I was pulling out the babies, I told him, I bet some ice cream would be good about now. And before long, we didn't have any more babies. We were having ice cream and we left the room. So we've got to go to their world, not trying to be reasonable. This again is where it's so important that we're making notes, because something might be triggering a hallucination or a delusion. If it's happening at the same time every day. I also had a gentleman that people were stealing his car, stealing his car, stealing his car at the same time. And he'd stand and he'd look out, and it was as the sun and it was shadows and the way that things were changing outside. So getting his wife to write down, it's happening at this time every day, and this is what he's doing before it starts. Now, how do we intervene before it starts? So limiting sensory stimulation and distractions, because people with PDD can become what's called hypersensitive to too much noise, too many people, too many distractions. So we want to just limit it. Find what works and use it over and over. Another thing we might have to do is we may have to put a curtain over a door so that they're not seeing that door, because that door might be where the people are coming in, the people that are going to take all my money and kill me and set this place on fire, whatever it is that they're doing. So we take away the door. Getting rid of mirrors is great. Now, this is with all dementia. So many times they don't recognize themselves. And why have you got another woman in this house? And it's them that they're looking at. So getting rid of the mirrors or covering up the mirrors. Making sure that we've got a routine, trying to stick to a routine as much as possible. And by routine, I mean even a sleep schedule and a toileting schedule. With Parkinson's, they can really start to have a lot of intestinal issues because of the Parkinsons. So it is important early on to get a toileting scheduled, where we're going every 2 hours or every 3 hours, figuring out a schedule. And then, of course, talking to care partners about prioritizing their self-care, so they don't become one of those statistics where the care partner dies before the person with the dementia does. Continuing to remind ourselves that this is not them, this is the disease. They didn't choose this. They didn't do anything to make it happen. We know that. They're going through a hard time. They're not giving you a hard time, they're having a hard time. These are 3 fantastic resources. They've got really good websites. The michaeljfox.org has a phenomenal website. I mean, you can just click, you can stay in it for a very long time. The Alzheimer's Association has a search, and you can go into that search and type in Parkinson's disease dementia. They've got great information. Their 800 number is a 24/7 number. It can be 2 in the morning and you don't know what to do, and you will get a live person if you call the Alzheimer's Association number. And then the Parkinson's Foundation also has an 800 number, and they have a great website as well. And here's our information. I think we're right at time. Great. All right, I saw we did have a few things come up in the chat. Let me see. Do you know why or suspect why the numbers of those diagnosed are increasing? I personally, from what I was reading, think it's probably just the research that we've got now that we didn't have then. There's something about all diseases, once somebody puts a face to it, you know that AIDS, HIV has come off of the terminal list now because people put faces to it and they started pushing money towards it. And people can live now an expected life expectancy with HIV, where that was just a very few years ago that was terminal. You got an HIV diagnosis and you were going to die. But people put a face to it. We pushed money towards it. That's what I think has happened with that. Can you address the relationship between Parkinson's dementia and Lewy body? So we did talk about that. And hallucinations are caused by PDD or the carbidopa levodopa, exactly. That percentage of people who have the hallucinations and delusions, what they'll have you do typically is, again, they'll have you keep that notebook. And in that notebook, we're going to know when we change the medications, and then they'll be able to see, are we having more of them? Are they getting more severe once we started the medication, or is it helping? So it's a lot of work on the care partner's part. How do you differentiate between cognitive changes due to PDD and cognitive changes due to multiple TIAs or stroke? You can see stroke or TIAs on an MRI. And so if you are continuing to have changes, they may do another MRI and look, because you can see strokes on an MRI. Great questions. Anybody else have any other questions or comments? Like I said, you'll get this recording and you'll get the slides as well. All right, well, thanks everybody. Jamie will also attach our calendar. And like she said, on our calendar, you can actually click on the calendar and it'll take you to a link to sign up for our other programs. We appreciate y'all being here. Stay safe, stay warm. Bye-bye.